Welcome to AETCM, the Emergency Medicine Channel. Session.
Yes.
A 85-year-old female, known case of CAD, type 2 diabetes, hypertension, obstructive airway disease, presented to the ER with complaints of fatigue since 2 days and giddiness and nausea of 2 days duration. On our initial 10-second assessment, the patient was conscious, oriented and obeying commands. Coming to airway was patent, breathing, respiratory rate of 18 per minute, saturation of 95% in room air, circulation BP of 130 by 80 millimeters of mercury, heart rate of 80 beats per minute, all peripheral pulses equally palpable. Coming to disability, GCS of 15 by 15. Coming to exposure, temperature of 98.2 degree Fahrenheit, GRBS of 130 milligram per deciliter. At this point of time, the patient was stable, so we just ordered for a ECG since MI can be typically present as generalized tiredness and elderly female with CAD history. We ordered only for an ECG which showed sinus tachycardia.
Okay, 85-year-old lady who has sprung with generalized tiredness. So first I will check the glucose. I wanted to check a GRBS.
GRBS, the exposure, we have checked GRBS, 130 milligram.
130 milligram, okay. So, and other most problem thing, generalized weakness will be electrolyte disturbances. So, an 85-year-old coming to the ED, the most common thing may be a viral prodrome infection. They might not be having fever. So, that will be the most common presentation. Reasons why I am telling, and can they present with stroke with similar symptoms? Stroke.
Yes, sir.
What will be the presentation like? What will be the typical presentations of stroke? Atypical. I am asking not the typical presentation. A typical presentation for stroke. An 85-year-old, what will be the
Altered behavior.
Altered behavior. So that whenever they are coming with altered behavior, you need to suspect a stroke. But here the lady was just complaining of generalized tiredness. Any breathlessness, anything she was complaining of?
Giddiness was there.
Giddiness was there. So definitely there is you need to look in for whether it's a stroke sort of a symptom. Because in ED, what we think is the most important diagnosis is the life-threatening one is the first differential. So stroke, as you said, giddiness, myocardial infarction. Yes, you need to rule out a myocardial infarction. The first myocardial infarction that I had seen is an inferior wall MI. He had never had any chest pain. He came with just with a syncope and giddiness. So that was his history. So giddiness, yes, elderly. Why again ECG? Not just to look for MI. Giddiness and generalized weakness can have complete heart block. Bradycardia, complete heart block can be a presentation. So that is why we are warranting for an ECG. So maybe that will be the initial investigation, and you haven't found anything significant in this investigation what you have done, and you went ahead with the further evaluation. Okay.
85-year-old female, known case of CAD, type 2 diabetes, hypertension, obstructive airway disease, complaints of fatigue since 2 weeks, associated with nausea and giddiness since 2 days. There were no history of any fever, breathlessness, orthopnea, PND, no history of any dysphagia, melena, loss of weight, no history of any chest pain, no history of any imbalance, no history of any vertigo as such, no history of any weakness, involuntary micturition, anything like that. Sir.
Okay. Suppose the patient is telling about giddiness to you. Okay. So giddiness, that is one of the most common presentation in the ED. So how will you evaluate a giddiness patient in this ED? What is the most important differential diagnosis that will keep in your mind?
One is we need to rule out any posterior circulation stroke versus BPPV.
Okay.
Other thing is Meniere's disease, labyrinthitis, any.
Okay, then 85-year-old. What could be the other reasons?
It can be any tumors in that causing.
Okay. CP angle tumors, they can affect. Oh, that is okay. One maybe lower down in the differential I will keep. Then
thyroid disorders.
Giddiness and presenting to the ED.
Generalized tiredness, fatigue.
Generalized tiredness, hypothyroidism, one differential diagnosis, but giddiness usually we won't see in thyroid disorder. Then bradycardia you have sent then.
Any hypopituitarism or renal insufficiency?
85-year-old, why she is presenting right now? Most important I need drugs, that is drug history. We have to look for the drug history. anything that is significant postal hypotension. So elderly, because their mechanism, everything will be not as good as a normal individual. So our mechanism will be, all the compensatory mechanism will be failing. Maybe some drugs that has been recently started, maybe previously it was not there. Long-standing diabetes. What is the problem with long-standing diabetes?
Diabetic neuropathy.
Diabetic neuropathy will be there, but on top of that, autonomic dysfunctions can be there. So when the giddiness is happening, that is the most important question. At what time she's having this giddiness, whether it is during the head movements, whether there is significant vertigo, precipitating factors like vomiting, and all those things you need to ask in for. So giddiness seems to be a simple thing when you think about in emergency room, but we have to look for a lot of other differential diagnoses. And most importantly, one thing what we are going to see in this patient is anemia. That is again non the classical presentation of anemia. The patient will come with fatigue, generalized weakness, giddiness, and all those things can be seen. So anemia is the another differential diagnosis that I think this patient had a hemoglobin of what range?
9.
Hemoglobin of 9. Okay, hemoglobin of 9. Usually, what will be the clinical presentation of anemia? Usually, you can just see like 10, 9, 7, 6.
Fatigue.
Okay.
Initial presentations.
Okay.
Actually, as the stage increases, worsening of hemoglobin, there can be even dysphasias, even neuropsychiatric disturbances, congestive cardiac
failure. That is what I wanted, because in ED, the most important one what you have to remember is the congestive cardiac failure. Like if the hemoglobin goes below 7 grams per deciliter, the patient will start developing all this cardiac failure, and they will present with cardiac failure. On top of that, you are evaluating and you are finding that this patient has got an anemia. So an elderly female has come to the ED with anemia. So that is the situation right now we are having. 9 gram per deciliter. We didn't find anything positive except for the anemia. Now this 9 gram per deciliter. So how will you proceed in evaluating this anemia?
In the ED setting, sir, we need to identify clinically whether it is an acute or a chronic blood loss, sir,
Okay.
based on symptoms. But there is no orthopnea, PND, no breathlessness, nothing was there. Patient was stable. So we were suspecting it to be a chronic problem. The patient has fatigue within for 2 to 3 weeks.
Okay, so you're thinking in terms of a chronic issue that got worsened and she has presented to the ED. Okay, agreed.
Then we have sent the routine investigations, sir.
No, in the emergency room, when you are seeing a 9 hemoglobin for a patient, the first question, as you said, is whether it is an acute or a chronic. What will be the next step that you will do? You have to arrange blood. What will be the next step? Simple thing.
Vitals we have to check.
Vitals we have to check, definitely. We have to just see, first thing is whether it is the microcytic, normocytic or macrocytic anemia. That is the next important thing that you need to remember. So, what is the most deadliest one that you can have for an anemia is an ongoing blood loss. So ongoing blood loss, what will be the type of anemia?
Normocytic.
Acute hemorrhage, it will be normocytic anemia. So when you are seeing a normal hemoglobin, low hemoglobin with a normocytic anemia, then there is definitely that warrants an urgent attention. There is some acute blood loss. So in ED, that's what I am saying. There are other reasons for normocytic anemia. I am not saying that will not be there, but in an emergency room setup, whenever you are seeing an anemia and normocytic anemia, always thinks first as the differential diagnosis for an ongoing blood loss. So you need to look in for the reason for an ongoing blood loss. Then, what are the other reasons for normocytic anemias?
Can be renal failure, marrow failure.
Okay, any bone marrow suppression, renal failure.
Even iron deficiency anemia in the early stages can.
They can present with normocytic anemia. Then, renal failure. Oh, okay. He has said renal failure, bone marrow suppression, bone marrow failure. Any of these things can come with normocytic anemia. But most importantly, remember acute hemorrhage. So the next investigation that you wanted to see when you are having an anemia is the macrocytic or normocytic. 80 to 100, less than 80 or above 100. So that is the question that you need to arise. If it is less than 80, you are thinking in terms of a macrocytic anemia. And what are the differential that you need to think when you are having a macrocytic anemia?
Macrocytic anemia, one is iron deficiency anemia, plastic anemia, thalassemia, anemia of chronic disease,
okay,
lead poisoning.
Okay, chronic lead poisoning and all you can present with. Okay, then you are having macrocytic anemia. Reasons:
vitamin B12 deficiency, folate deficiency, alcohol, hypothyroidism.
Chronic alcoholism, alcohol. Then drugs. Which drug can cause anemia? Which drug can cause macrocytic anemia? I can tell you this patient has been on medication for seizure. I can give you a clue. Phenytoin, yes. Phenytoin is one agent that can cause. Phenytoin again, one drug that, again, when we are discussing about this giddiness and vomiting, I just thought since we have come up with phenytoin, very rarely phenytoin toxicity. If the patient was on phenytoin, they can come with brainstem dysfunction, like they can come with giddiness, vomiting. We had a patient, we were evaluating, then we are finding no cause why she's having these symptoms. Then we saw the drug chart, she's having on phenytoin. Then we are sent for the phenytoin level, and phenytoin level was very high. She was taking it for a seizure disorder. She had hyponatremia. Because of phenytoin, she developed hyponatremia and came to us for admission. Then we found out that she has got phenytoin, dosing was increased. She was being taken from an outside hospital for seizure disorder for a very long without any follow-up. Once we stop that drug, her symptoms start improving. So that is one agent, but phenytoin also can present with macrocytic anemia. So basically, whenever you see an anemia in ear, airway, breathing, circulation, that resuscitation you have to do. But the next important question, what is the type of anemia that the patient is having? Microcytic, macrocytic, or normocytic? For each one differential diagnosis we have told, and from that background you need to evaluate further. So you are getting a microcytic anemia, the most common reason being is the iron deficiency anemia. So iron deficiency anemia, and what is the next most common cause in India for iron deficiency? Hookworm infection. So that is the next most common. So the most importantly, we have to treat iron deficiency, as well as you need to give albendazole for this group of patients if they have not received further. So that is the two important things that you need to remember. So what all investigations that you will choose for microcytic, macrocytic, and normocytic, or in general anemia? So we have a patient who has come to the ED. You have diagnosed this patient is having anemia, and how will you evaluate the patient? So we need to know. We have to differentiate between these different types. So CBC we have done whether microcytic, macrocytic, or normocytic. The next thing, what all investigations needed. So imagine that this patient had a microcytic. I think she had a microcytic anemia. So what all investigation that you will ask for?
So initially, since patient was stable, we sent for the lab investigations rather than point of care.
Okay.
First we have got the hemogram results where HB was 9, total count was 6,000, platelet was 2,50,000. CRP was also normal. So we identified as a chronic blood loss. Second, we come to whether it's a...
We identified as a chronic blood loss. Okay, chronic anemia I will say. Chronic anemia I will say. Chronic blood loss we cannot say unless and until we are getting something positive.
Chronic anemia. Second, we need to know whether it is a single lineage or a tri-lineage issue.
Okay.
Everything was normal except HB was on the lower side. So it was a single lineage issue.
Primarily marrow looks okay. Because if there is pancytopenia or there is bicytopenia, we can say that there are other involvement also. Here there is only anemia.
Then we send the blood indices and the reticulocyte count, and the reticulocyte proliferation index came to be less than 2.5. So it's a hyperproliferative anemia. And then the blood indices came as microcytic hypochromic picture, MCV of 72, MCH of 26, MCH of 19, and MCHC of 26. So microcytic hypochromic pictures are. And the peripheral blood smear also came as microcytic hypochromic anemia with anisocytosis was also there.
Okay. So investigations that you wanted when you see this, one is you have to look for whether it is an iron deficiency anemia. So that is the next investigation. Most important investigation that I will say is a peripheral blood smear. So peripheral blood smear followed by your serum iron, ferritin, and total iron binding capacity that you need to send. So how will you interpret all those investigations? Serum iron, TABC, and ferritin.
And we come to microcytic hypochromic anemia. We send the iron workup for iron studies. We send serum ferritin, total iron binding capacity, serum iron, and also red cell. We calculate from that the transferrin saturation and the red cell distribution with and the Menser index. In this patient, the serum ferritin was 17. The normal range is 30 to 300 nanogram per milliliter.
So it was on the lower side.
Lower side, sir. Serum iron was 19 microgram per deciliter. Normal range is 50 to 150, sir. That also on the lower side. So then we come to
TABC.
The total iron binding capacity was increased, sir. 400 range. Normally 300 360 was the
So that is again pointing towards probably you having an iron deficiency anemia.
Then we calculate the transferrin saturation, that is serum iron divided by total iron binding capacity 100. That comes to around 5%. Sir. Less than or equal to, normally it is 33%, less than or equal to 19%, again point towards iron
deficiency anemia. So we are probably dealing with a patient with iron deficiency anemia. Now we should know what is the most reason why she is having iron deficiency anemia. So for that, you have to plan your investigations next. So what is the reason?
The causes of iron deficiency anemia can be either due to increased demand or due to loss. And in increased demand, normally in pregnancy, in adolescents, in infants, there can be increased demand. And due to loss, it can be acute blood loss, chronic blood loss, heavy menstrual bleeding, phlebotomy patients. There can be, and when there is increased other causes like malignancies and decreased absorption like in celiac diseases.
Nutritional. Which is one of the most common thing. It is nutritional and hookworm infestation. So these two things we need to keep in our mind. Okay. So your investigation should be planning. We have found out that this patient is having an iron deficiency anemia. So we should find what is the reason for this iron deficiency anemia. For that reason, we have to proceed further. So as this lady, an elderly lady coming with anemia, the most important thing what we need to rule out is a GI blood loss. And malignancy is one thing that we need to rule out first. So GI blood loss, already on antiplatelets for coronary artery disease, maybe a simple gastritis, maybe an ulcer bleed, or maybe an underlying GI malignancy, a colon malignancy we need to rule out. So investigation should be planned in such a way that we are evaluating these things. So maybe initially you can do for a stool occult blood and you can look for whether it is becoming positive. So this lady definitely requires an upper GI endoscopy as well as a lower colonoscopy needed to be done. To look for maybe 85-year-old, if they don't want to go for an invasive procedure, you can even take a CT and look for a gross evidence of any malignancy. Anything is there also, it can be done. So once you diagnose that it is iron deficiency with mild blood loss, there is stool OB turned to be positive. So how will you plan your management?
Sir, we need to calculate the total deficit, sir. In this patient, we will calculate total deficit at 2.3 into body weight into the desired hemoglobin minus current hemoglobin plus 1000 to replace the iron stores. In this patient came to around 1500 was the requirement, sir. So we supplemented the patient with ferricarboxymaltose because if we start the patient on oral tablets, one is that adherence and compliance can be low.
Again, it can cause gastritis, vomiting, and it can further decrease the absorption.
And also we need to supplement for 6 months even to correct the iron stores. So we supplement the patient on, as we have ferricarboxymaltose in our pharmacy. So we started the patient ferricarboxymaltose 500 OD we have started, sir. And every 1 to 2 days we have replenished, sir.
Okay. So totally 3 doses we are given, and that is was the requirement for this patient. And after that, what will be your advice? Is that enough?
No, sir.
So how long you should be treating her? That is the next question.
The symptoms get relieved by 2 to 3 days, and the changes in SB can be seen only after 3 to 4 weeks, sir.
Okay, so my question is, how long you need to treat an iron deficiency anemia? So how long?
6 months.
No, till the hemoglobin level is normal, and after that you have to treat for, even if the hemoglobin level is normal, you have to treat for the next 3 to 6 months. So don't stop once the hemoglobin level is normal. Don't stop the treatment there. You need to replace whatever be the replacement needed for the next 3 to 6 months. At least you should continue the treatment. Then only you should stop. By looking at a hemoglobin of 12 gram per deciliter, you should not stop the treatment. That is the thing. Once it is 12 gram per deciliter, okay, then 3 to 6 months you continue the treatment. Then you stop. Either by means of your oral tablets or monthly or weekly injections, or whether you can give syrup, dexor. All those things is a possibility. But always remember to supplement along with folic acid. So that is the other this thing, folic acid with iron. So what will be the advantage of you when you give with folic acid?
One is we can correct the vitamin B12 folate deficiency also, sir.
No, folic acid with iron.
Absorption
will be better. Yes, that is the main reason why you are giving folic acid with iron supplement. So that is for your microcytic anemia. So we have for this patient, that is fine. Now coming to the normocytic anemia, how will you work up for a normocytic anemia?
One is based on the peripheral blood smear we will see, and
again ultrasound abdomen is one of the key investigation in any anemia, looking for hepatosplenomegaly. So if there is splenomegaly, what does that mean?
There is hemolysis.
So one important thing, you will get hemolysis. Probably there is a pathology which is happening for a longer time, so which need attention. So normocytic anemia or a microcytic anemia or macrocytic, the most important investigation that you need to see one is what is the worst scenario when iron deficiency? Can it cause thrombocytopenia? Iron deficiency anemia? It can cause. The worst presentation can be an iron deficiency anemia with thrombocytopenia. The patient can present if it is severe iron deficiency. So don't think that iron deficiency anemia you just need to treat iron alone, but they can come with thrombocytopenia also. So that thing you can just keep in your mind. Even vitamin B12 deficiency, what will be the presentation? Vitamin B12 deficiency.
Neuropsychiatric symptoms can
Neuropsychiatric symptoms they can present, or else they can come with just the evidence of peripheral neuropathy. They will just coming with peripheral neuropathy, numbness, and they will have. You will think that this patient is having a stroke. You will be doing maybe an imaging because the patient is present to the ED maybe with is unable to walk, gait imbalance. Because of the peripheral neuropathy will be the most important reason. So you do all your tests and you are finding out that this patient is probably having a posterior circulation stroke. It has nothing to do with this. Along with diabetes, vitamin B12 deficiency, you just imagine he has got vitamin B12 deficiency as well as this thing, and it's going to be a worse. So how will you manage your macrocytic anemia, vitamin B12 deficiency?
we can supplement with cyanocobalamin, sir.
What is the reason for vitamin B12 deficiency?
The maturation is not happening, sir, in the process.
No, what is sorry? That is understanding. What is the reason? Etiology behind.
Intake majorly.
Even the patient is coming and telling, I am taking all non-vegetarian food. You are finding to have vitamin B12 deficiency.
Cofactor deficiency.
I am giving you a history that this patient is having a vitiligo also. A patient coming to you to the ED with vitiligo, pernicious anemia, so intrinsic factor deficiency. So they will not be absorbing this because of the absence of intrinsic factor. So whenever you are seeing an anemia, vitiligo with macrocytic anemia, you think about this. So when it's probably an autoimmune disorder, so what you need to do here, you need to give IV supplementation. So IV supplementation, either IV or IM, both are equally good. But initially maybe you can give IV preparation of vitamin B12. So what is the frequency that you wanted to use?
Initially we will give 100 to 200 once daily for the first 1 week. Then weekly once for the next 1
1000. You can give 1000 microgram, not 100. You can give a little bit more. 1000 microgram IV you can give. Maybe for the first 5 days you can give IV. Then weekly once, then monthly once, and maybe yearly once. If it's a significant B12 deficiency, and if they are able to tolerate oral supplements after the initial correction, you can give them on oral supplementation or sublingual preparations of vitamin B12 is also available. You can supplement them with folic acid also. Chronic alcoholics, that is in other group of patient where you can find this macrocytic anemia. So what are the other peripheral blood smear features of your this thing, vitamin B12 or chronic alcoholic? What are the peripheral blood smears? Basophilic stippling, then all the spirocytes, the cells and all you will be able to see in the peripheral blood smear, and you will be able to identify that it is an primarily and related to alcohol. Okay, so peripheral blood smear is the one key investigation that you need to do for any patient that is coming to the ED with anemia. I am not discussing the hemorrhage part because that is just the resuscitation. Now the question we'll ask is, when you want to do blood transfusion in anemia?
One is, sir, in the case of any acute blood loss with the symptoms of congestive cardiac failure, sir.
No, when?
In normal patient, less than 7 or 8 we keep up the cutoffs.
Okay.
In CAD patients, we will keep around 10 as our target, sir.
9 to 10. There are different guidelines. Some even say up till wait till 9, some till 10. So maybe basically around 9, less than 9 gram per deciliter, the patient is symptomatic, you can treat. But it is an acute blood loss. Don't think about the hemoglobin. If you are having an hemorrhagic shock, it is not to think about you don't look at the hemoglobin. You just see the blood loss and hypotension, you need to give blood transfusion. I am saying here, when a patient is having a chronic blood loss and he has come to the ED, like this lady we had discussed, I am not regarding a traumatic blood loss, blood transfusion, that is different. And upper GI blood loss, different. A patient coming with upper GI bleed, hypotension, you need to give blood transfusion irrespective of the hemoglobin. But one episode of hematemesis, but hemoglobin is somewhere around 9, but the patient is asymptomatic, hemodynamically stable, you can wait till the hemoglobin drops below 7 or 8 gram per deciliter. So in cardiac failure, your trigger is a little bit more, or we need to go with 9 gram per deciliter. So in general, what you have to do for an anemia, when you have a patient with anemia, our concern, you have to look for other signs. What are the other signs that give your clinical examination clues that you can give? These are the differential diagnosis. Starting from the head, you can start.
In iron deficiency anemia, sir, there can be neuropsychiatric or hyperactivity symptoms.
Starting from the head.
Hair loss.
Hair loss, the most common hair loss. Iron deficiency anemia, that is one of the most common reason for your hair loss. Hair loss, iron deficiency anemia with hypothyroidism. Imagine hypothyroidism, as well as iron deficiency anemia. So hair loss. Then neuropsychiatric. Then coming to the eyes. Jaundice. We are hemolysis.
Hemolytic anemia.
We are thinking in terms of hemolysis, looking for the pallor. Then coming to the oral cavity.
Angular cheilitis.
Angular cheilitis. Glossitis. Oral candidiasis. Okay, then coming to the chest, abdomen, anything significant that you will be able to see?
Splenomegaly.
Splenomegaly. Okay, hepatosplenomegaly. Splenomegaly in general. Then skin lesions. That's what vitiligo that I have told you. Hyperpigmentations. Yes. Then
Nail flattening, koilonychia.
flat koilonychia, brittle nails. Then going down. What are all the other features that you can have? Skin. Anything else?
Then it's like nail changes
Nail changes, okay.
and then peripheral neuropathy.
Peripheral neuropathy for vitamin B12, okay. Then patient was on some supplements, okay. I'll give you a clue. Neuropathy, you have to, just I want to give some interest. One patient we had admitted like 3-4 months back. One lady we had admitted. She was taking some herbal supplements and she has come to us. And imagine that lead poisoning. So you have to look for lead poisoning. So what are the other things in the oral cavity that you have to look for? Discoloration. What is the lines called as? Meese lines. You have to look for Meese lines. So we had a patient. We had 2 patients. One patient, she came in for anemia workup. Then we found out she was having lead toxicity. And other fellow who came with GI, abdominal pain, chronic abdominal pain. Then we found out he is having lead poisoning. So lead poisoning, we cannot say. They were taking some over-the-counter drugs for the management of their diabetes. Something they got through online, and it was containing high amount of lead. So anemia is one thing that in ER we need to extensively evaluate. But our idea, we will not be go ahead and evaluate every cases, but concern, you have to simple thing what you need to remember: microcytic, macrocytic, normocytic. What are the differentials under microcytic? What are the differential under macrocytic? Normocytic. So normocytic, I am saying I will be more concerned. Okay, normocytic, okay, there is some ongoing blood loss, 6 hemoglobin, normocytic anemia, I am very much concerned. There is something grossly going wrong to this patient. Suppose this lady is having a renal failure also. So how will you plan the correction of anemia for that patient?
Initially, we need to.
You have corrected the anemia, then what else you will suggest her to do? Erythropoietin injection. Because erythropoietin injection, once the renal failure happens, initially you treat it, then if she's having this also, you have to give supplement with erythropoietin, maybe 5,000 or 4,000 to 5,000 unit weekly until the hemoglobin is building up. So that is the additional thing that you need to keep in your mind. Okay. Anything else that you want to add on? Okay, fine. Thank you.